The systemic circulation is oxygenated because it's coming from the left ventricle. Here our video, I'm going to be talking shortly about hypertension. And so what we're seeing here is there's inflammation on the endothelium, the inner lining of a blood vessel. Let's say you just had a lungful of cigarette smoke, or maybe you're overweight. These plaques form, and eventually they're going to occlude the artery. They don't disappear like that. We wish they did. Let's look at the heart, aorta. We're going to go right subclavian, coming off the stem of the brachiocephalic. Think of brachio meaning arm, cephalic head, and indeed that's what we're seeing. Subclavian goes to the shoulder and arm, carotid to the head. And we have a pair on the other side, but we don't have the brachiocephalic. We just have the subclavian left side, your patient's left, and the carotid, and on to the descending. If we're going to look at the thoracic here, we'll see that there is the bronchial, and this makes sense. Instead of just memorizing this without any purpose, bronchial, think of bronchi or lungs, esophageal, so the stomach here, mediastinal, which you're not familiar with that word most likely, and that's going to go kind of between the lungs and towards the vertebral column, because we need to keep the spine and the tissues around here alive. Pericardial, peri means around, cardial, cardiac, think of heart. So this maintains the membranes and the tissues of the heart. Thoracic is what we're talking about here. This is all part of the thoracic. The ascending arch of the aorta right here, descending here. Phrenic is we're only going to talk about the superior here because the inferior is not part of the thoracic, and that's going to innervate the diaphragm to help us breathe. Abdominal, this is where I said we get into the inferior phrenic. Here it is, inferior phrenic, influencing our breathing. Then lumbar, as the name suggests, is going to be our lower area. Celiac trunk, there's several important blood vessels of the celiac trunk. Common hepatic, we think of the liver coming off of this large artery. Gastric, we think of the stomach, and the splenic for the spleen. Mesenteric, we have a superior and inferior, and these, it doesn't show, but I'll have a diagram in a little bit that will show you that these are connected to parts of the lower digestive system, like the colon. Superior and the inferior down below, because the colon is going to wrap in a in shape, if you will, or horseshoe shape like that. Renal is kidneys. Gonadal, we think of the reproductive system, whether it's ovaries or testes. I talked about the inferior mesenteric, and finally the common iliacs. So the iliacs are going to divide into right and left sides, and they're going to go on down into the legs. Continue with the systemic, and this is the diagram I talked about. It's not quite as clear as I wanted, but I like the way it's built because it helps us. Because there's the celiac trunk, and we can see the splenic now, and we can see the hepatic going to the liver. Not really showing the liver there, and we see the renal going to the kidneys. There's a mesenteric. I talked about the colon here, iliacs in the leg. So nice little diagram. Let's take a closer look at this subclavian. The right side is going to go into the axillary artery, continue down to the brachial. Brachial is arm. This is where we can take a pulse, and also where we put pressure if there's extensive bleeding sometimes in the lower part of the arm. Radial on the radial side of the bone, ulnar on the ulnar side of the bone. Deep palmar arch, so deep means we're not going to see it. Then we have the superficial palmar arch and the digital arteries. Now, these are important when you're setting up an IV because You do not want to puncture an artery unless you're doing blood gases, and most of you will never do blood gases. That takes advanced skills. And so anytime we're doing IV, if you hit these, your patient's in some trouble. Okay. I kept this diagram because I liked it so much. Let's look at the pelvis, lower limbs. So some of this I'm not so concerned about, like the inguinal and the sacral, but I do want to track the direction of the iliac, because iliac you have an external and internal moving down, and we have the femoral, popliteal at the kneecap to the anterior tibial, and there's also posterior tibial in the back, and finally at the dorsalis pedis, which is where you can take a pulse on a patient. Let's say your patient is unconscious and you're not sure what's going on. You can palpate this this artery right here and get a pulse, and down into the dorsal arch of the foot. Yeah, the old name is dorsalis pedis. We just call it the right dorsal artery now. Now, we also have deoxygenated blood, and that is, you know what? It's parallel to the arteries. And well, let's take a look at this diagram. So we have the oxygenated blood surfacing the major organs. There's the hepatic, that would be this gastric for this stomach. There'd be a splenic. There'd be the mediastinal for the colon and so forth. And so there's a parallel system that is going to pick these up. And for many of them, their names are just similar to the systemic flow. There's some exceptions like hepatic, portal, vena cava, we know that one. That's vein returning blood to the heart. Okay, so let's just look at a few of these. I'm not going to expect you to know all these, but there's the renal. Inferior vena cava, certainly bringing blood back to the heart. Axillary, we saw that one. I'll talk about the cephalic. We saw the subclavian. The jugular is the one that's going to drain blood. It's going to run alongside the carotid. Do you remember the common carotid? So the jugular is the companion. We have the carotid bringing blood up, the jugular bringing blood back. There's an internal and an external jugular. Brachiocephalic, we learned that word as well for the systemic. There's the iliac, external, and there's the internal here. So these are all very familiar. Femoral, there's a femoral artery, so there's a femoral vein. So I like the way the names in the popliteal of the kneecap area. Now we don't have a saphenous in the systemic flow, so that one's a little different. The saphenous is neat because you can slice out a section of the saphenous sometimes and suture it in somewhere else in the body. If we need a blood vessel somewhere, we can just take it from the saphenous, and it's very accessible. I mentioned blood, and I mentioned how you have to be careful of the systemic arteries. Let's look at an IV drip or blood draw. We're going to use these veins in the order of preference. First, the median cubital, which is right in the antecubital fossa, in the inside of the elbow here. That's the preferred site. You'll see it here as well, the lower diagram. And that one tends to jump out. It tends to be a large one. You can get a good blood flow. And set up a line there. Cephalic is the one we use. It's on the outer part, so it's a lateral vein that is the best one for obese patients. Tends to be, you can slide it right in. You can palpate it pretty easily. And the basilic is the one you want to avoid. And take a look at why do we avoid the basilic? Any idea here? Well, do you remember the brachial artery? Brachial artery is a large artery that's pumping blood to the hand, and there's the brachial nerve as well. And so if you miss the basilic and hit the brachial nerve or brachial artery, then your patient's in a lot of pain. Okay, palpation is the best method to locate a good vein. We don't care about sight. Sometimes you don't even see the vein that you're going to enter. Hands require a large gauge, which means a small needle. It's kind of bizarre. Large gauge, small needle, like a 24 or 23 gauge, and a pediatric winged infusion. We'll call them butterflies. Right there's a nice example. It's tricky though, because you need two hands here to get this one done. Hypertension. All of us will experience some hypertension as we age, but you don't want it too fast and too much. It affects the heart. We have this hypertrophied heart. Look to the right. And why does this happen? Well, let's talk about that. Let's start with this. If you remember that introductory video, we have a damaged endothelium here, and platelets are going to attach to that. They're going to attract red blood cells and fibrin, and then we get this platelet plug. And so it keeps us from bleeding to death, and then there's some calcium deposited on here. The diagram's not showing. Calcium's going to harden that plaque. Now, it saves our life, but it slowly kills us because this is going to decrease the diameter of the lumen over time. And we can see it lower right. This is how, okay, when we're young and healthy, we have these slick walls and nice smooth blood flow. But then as we age, especially if we don't age wisely, smoking really speeds this up, because smoking is going to, some of those chemical particles are going to end up in the bloodstream, and people don't realize this. And I wish movie actors didn't smoke, because they're sending the wrong message. You're basically killing yourself. Yeah, it's true, because these plaques are building up. Thousands of them, and pretty soon the blood flow is diminished, and now the artery can't expand and recoil. You see, normally with each beating of the heart, this blood vessel is going to expand, and then it's going to recoil. When it recoils, it just shoots the blood forward, and then the heart doesn't have to work as hard. But once the vessels become hard, then, do you remember that picture, the previous picture? The walls of the heart become enlarged, and so that pumps harder, and harder pumping is going to destroy the vessels, and it's a feedback loop that eventually destroys our kidneys and eyesight. It's a system-wide destruction. So let's be good to our bodies. Keep the weight. We need a little bit of fat to be healthy, but we don't need the big bodies, and certainly you don't need to smoke.